All right, everybody, good morning on February 23rd, 2021. It's good to have everybody together this morning. We're going to start off first with our public hearing for the county tax budget, and this is the time and place for the public hearing of the 2022 Myrtue tax budget. So, Christy, you've got some opening slides to share with us, I believe.
Yep. So in 2021 is our tax rate that we are going to look at today. So just kind of, I passed these out because this is a little difficult to read, but we always like to do a comparison of where we are to other houses in the state. So based on the dollars that we generate from our tax rate, we are 10th lowest in the state. So we're still maintaining that, been pretty consistent at that rate. Hospital tax rates by the rate, which is, dependent on property tax values in the communities in which they're covering. We are 15th lowest. That is, we were 14th lowest last year. So we're still right in there, and it's really, again, back to the dollars that we asked for. That is, I think, more important. So we published our budget in the paper according to regulations, no more than 20 days and no less than 10. We published a tax rate. Our tax valuation for current fiscal year was $921 million, and it went up $17.7 million to almost $39 million. Not as large of an increase in property tax valuations as we saw last year. Our current tax rate is $1.15 per thousand. We had discussed with the Finance Committee, and Barry and I discussed that we would ask for approval to leave our property tax collected funding at the same rate as what we are in this current fiscal year. The same dollar amount, so it would be at $1,062,650. That would bring with the new valuations, that would bring our property tax rate to $1.13, which lowers it 2 cents per thousand. And this is just a copy of our public notification that was published the 9th of February. So we get our general fund taxes, which you have to max out at 27 cents per thousand in order to ask for any additional levies, and we levy for our Social Security FICA, our employee benefit of FICA, and also to support the ambulance commission and the ambulance service in our county. But like I said, we had a Finance Committee meeting on this before it was published and discussed it with the members, and they, can talk about it if they'd like, but it was recommended at that time that we move forward with this rate. And we had no comments. I had no comments. I don't believe Barry received any comments from the community or the public on our notification. Any questions on that?
So if we just note that in the minutes that nobody commented to administration and there are no public here with us this morning. Finance Committee, did you have any comments? Jim, Janine, Leona, anything?
No.
No. I just
Okay.
think it's nice that we can keep it consistent.
Thank you, Jim. Yes. The dollar amount in this proposal would stay the same. So with that, I would entertain a motion to approve the.
I'll make a motion to close the public hearing.
Thank you, Jim. That's what I was going for. Somebody else?
I'll second it for you.
Tom seconds closing the public hearing. All those in favor say aye.
Aye.
Opposed, same sign. Okay, we are resumed in our regular meeting. I'll call the meeting to order officially. You got the time there, Ruth? 7:37, 38, somewhere in there. All right, so we will move to the adoption of the 21-22 budget and certificate of taxes as presented in Christy's presentation. Entertain
I'll make a motion to approve.
Jim has moved. Is there a second?
I'll second.
Janine seconds. All those in favor say aye.
Aye. Aye.
Opposed, same sign. All right, the budget is adopted as presented.
I have to go in online and adopt that and print out a form for Leon and Terry to sign. If you could just hang around a few minutes afterwards, I'll get that done.
Thank you, everyone, for the information gathering and putting the budget together, so appreciate that. All right, we are moving forward and into Department Educational, and Dr. Steve Finn is with us this morning. So good morning, Steve.
Good morning. This is my yearly update to the board. I'm Steve Finn. I've been the rehab director. This will officially up my 28th year. Department has changed a lot over the years. If we consider our staff, if we look between PRN versus all the way up through full-time, we actually have 9 physical therapists, 4 physical therapy assistants, 3 occupational therapists, 2 speech therapists, 3 front office managers, and 2 exercise science clinicians that run our Live Well program. There's a picture of the group. With such a large group and a lot of talent within those individuals, the hospital, we've been able to run a lot of subspecialty programs, anywhere from aquatics to dry needling to concussion management programs. I'm just going to highlight a couple of those today, but I refocus on our joint replacement program and our women's health pelvic floor program. Looking at Dr. Base's total joint replacements, historically over the last several months, he's been coming twice a month, typically doing 3 joint replacements on the surgical day. I know that's going to change in the near future. Now he's switching, that he'll be coming more frequently. I think it looks like that some months up to 4 Mondays out of the month. I think the goal is to do 2 joint replacements for sure on those days, and possibly a 3rd one if the need arises. What those patients look like after they've had their joints replaced on that morning or early afternoon, they're still getting up that same day with therapy, and 90% of those folks are being discharged the following day. Now this is a coordination of a lot of folks doing a great job, and we just feel very proud of how well that the joint program has been running so far, and look forward to even more of it in the future. The second program is our women's health pelvic floor. Linda Riding had established this several years ago and had done a great job. She retired a few years ago after 43 years, and we actually went about 3 years without being able to offer this program. And now with the addition of a new staff, Tina Bryant has been running this program now for probably about the last 8 months, and she's done a wonderful job of that and a well-needed service for our community. And she's looking at anything from pelvic pain to incontinence. And also, a lot of folks tie into this with the low back pain, and she's done a really good job of that. And she has a lot of tools to utilize, from biofeedback to manual therapy to home exercise program to electrical stimulation. And she's just done a wonderful job of resurrecting this program and getting going for us. That's all I have. Any questions or concerns? Thanks, Jeff.
Anybody have any questions, Steve? All right, thank you.
Thanks, Terry.
Appreciate the work of the group across the street and all the talent that's there. Thank you, Steve. All right, approval of the minutes from our last meeting. Anybody would like to move?
I'll make that motion.
I'm going to give it to Tom first. Rick, will you second that?
I'll definitely second it.
All right, you're it. It's a second to approve the minutes of January 28th. All those in favor say aye. Aye.
Aye.
Opposed, same sign. Okay, motion carries. Minutes are approved. Dr. Scott Markham is with us with the medical staff meeting summary. Good morning.
Morning. I wasn't at this meeting actually, but I can kind of go over it. My daughter just had.
We weren't either, so we'll let you lead.
Congratulations.
Thanks. So, we still continue to see COVID, not as many. Basically, understand is we're getting 200 doses of vaccine a week. They kind of suspended allowing people to call in and register and get signed up just because they had over 1,500 names, which is very frustrating. But they couldn't, because a lot of them were desperate. But they're opening it back up, and people want to get on the list. So just moving forward is we don't hold on to any doses as soon as it's here. It's been good. So public health is doing a great job, and they're working with their pharmacies as well. We're not doing as many flu tests because people are wearing masks, so we haven't seen as much flu at all. Still, when people come in with fever and aches and pains, and not only will we check them for COVID, we'll check them for flu as well. We just don't have as many tests, don't require as many this year. As far as the obstetrics thing, it's just kind of a culture change. Traditionally, when we'd be pregnant, we didn't really want to see them until they were 8 to 10 weeks pregnant. Sometimes first-time moms especially don't want to wait that long. They get a little nervous. Just want to make sure everything's okay. So they've come up with a different way of approaching it with an Amenorrhea Visit, where they can come in and basically talk about what's going on with their bodies, get their prenatal vitamins, and kind of coach them along. It doesn't wrap up into that global charge, so it's just a way of kind of just getting them into the clinic, visiting with them, and kind of helping them through that first trimester. The ultrasounds is just what we're going to do. As far as Dr. Abelushi, he's going to be kind of a neat addition. Really nice guy. He works out of the Bellevue Hospital Med Center. So the things he's going to offer for transesophageal echoes are great. Basically, it's another echocardiogram, but the probe is through the esophagus, so you really get a good look at the heart. You can look to see if there's vegetations on the valves and things like that. So, like, we're looking for endocarditis and things like we traditionally have to transfer those patients now. We can probably keep them. The calcium scoring is just another way of evaluating for coronary disease. It's they kind of combine it with these little calculators they have to figure out your risk of having coronary disease and your risk of heart attack. Like my calcium score at my age is basically based on your race, your age, if you smoke, if you have diabetes, what your systolic blood pressure is, and they have this calculator, and they combine that to calculate your risk score, then the calcium score, it can add some more information, see if you really need statin therapy. Cardiologists are really big on getting people on statins, and if you get online, a lot of patients are reluctant to take statins, but statins do actually improve morbidity and reduce, your coronary risk if we push it. But it's just another tool we can use to evaluate these patients. The cardiac CT is really interesting. Actually, my feeling is it would be more CTA, where we're actually looking at coronary arteries and seeing, and they're pretty sensitive, up to a 50% luminal blockage or narrowing. So something we can do in working these patients up with atypical symptoms, or if they just want to see what the risks of coronary disease are. A bunch of little housekeeping things there. Dr. Schepfer, he's going to be replacing Kip Anderson, who's our pain management guy. He's actually an interventional radiologist as opposed to anesthesia. Kip was a nurse anesthetist. This guy's very well thought of. The vertebroplasty and kyphoplasty that he's offering, I guess I'm going to have to relearn about that. It's not a new procedure, but it's kind of fallen out of favor. People are just not really doing them. It's a treatment for compression fractures, especially in the older women or osteoporotic. Sit down too hard, that vertebral body just gets compressed, and it's a fracture. It hurts. And the intervention would be to put a trocar in there and kind of balloon that up and fill it with cement to try and re-expand it a little bit. When it came out 10 years ago, I thought it was going to be the standard of care, but it just kind of fell out there, and I don't know why we don't do more of those, but let's have to see how that works out. And Barry will talk about all this other stuff. The COVID clinics we had a designated provider to do the COVID clinic in the morning and one in afternoon. We're just not seeing the numbers, so we're just gonna go away from that. Any questions for me?
It's like you were there.
Well, that is.
But
A little over there,
congratulations, so,
Oh,
yes,
yeah, thanks. Yeah.
yes. Well, thank you for that. Does anybody have any questions for Dr. Markham? All right, have a good day. Thank you. Next up, quality improvement report with Ann. I haven't said good morning. Good morning, Ann. Turn it over to you.
So I'm here to talk about Compass, which is our hospital quality improvement contractor. So in September, the Centers for Medicaid and Medicare Services announced that the Iowa Healthcare Collaborative as one of the 9 hospital quality improvement contractors. And so there's 9 contractors for the whole United States. So for the one that the Iowa Healthcare Collaborative is doing, that includes 4 states. So it's Iowa, South Dakota, Mississippi, and Kansas. It's 275 critical access hospitals, and we are one of them. So that's 8,000 clinicians and 24 communities. The term of this scope of work is 4 years. So in the past, the Iowa Healthcare Collaborative has led several federal contracts aimed at advancing hospital quality improvement. For the past 8 years, our hospital has participated in each scope of work. So collectively, the hospitals prevented nearly 37,000 harms with a large cost savings. So moving forward for this scope of work, we had to identify 2 priority focus areas. And the first priority focus area is in behavioral health, and that was identified as an area of need on our community health assessment. And so we will be screening patients for clinical depression, and if that screening comes back positive, a follow-up plan will be completed. And then the other focus area is on care transitions and readmission discussion, and that's assuring patients have an annual wellness visit. And so during that annual wellness visit, we look at like diabetic patients, making sure that their blood pressures are under control, or their blood sugars are under control. Patients who have high blood pressure, we want to make sure that they've had medication and that their blood pressure is controlled. We do screenings for fall, influenza, breast, and colon cancer, just to name a few things that we do in that annual wellness visit. And so moving forward, our other areas of focus, there's 46 measures in total that we either self-report via a portal to the Iowa Healthcare Collaborative, or it goes through claims. So most of these measures are the same that has been in the previous scope of work. The new one that I see is antibiotic stewardship. That's new. And some of the other ones might have changed a little bit. And I just want you to know that this affects each clinical department. They put these measures on their quality improvement report, and they report their results to either system-wide or medical staff quality improvement. So it involves all the practitioners, lab, pharmacy, diagnostic imaging, med-surg, UR, OB, ER, surgery and specialty clinics, infection prevention, and then the business office for the claims. So it really is a team effort to make improvements on these measures. And then I just thought this was a good thing. Dr. Tom Evans does such a great job as the president of the Iowa Healthcare Collaborative. That, you know, we believe our work is deeply rooted in innovation and evidence-based best practice. Can and should be broadly applied as healthcare in America faces perhaps profound challenges. So any questions about this new scope of work?
I think it sounds great. How many hospitals did you say in the state are engaged with this?
Well,
Did you share that?
there's 275 in the contractor that we're involved in.
Okay. Not just all Iowa hospitals.
It is
It is, okay.
all critical access hospitals in 4 states.
Will this be added to the measures you already do?
Most of the measures are the same as the previous scope of work. There's a few new ones. Antibiotic stewardship is new, and a couple of the other ones have changed just a little bit.
Okay.
So we already monitor the majority of these. This is the new scope.
Okay.
Good question.
Sounded like a lot of work, but, okay.
Sounds like it does a lot of good, so.
Yes, it does.
Appreciate it. Thanks, Ann. All right, moving forward, the approval from the Personnel Committee related to credentialing this month.
Okay, with respect to the credentialing, we have 3 initial approvals. Dr. Arif Al-Balushi, I believe, for consulting cardiology, Gary Gillian, consulting teleradiology, and Aaron Williams, for consulting pediatric dentistry. With respect to reappointments, I'm looking at Alexander Bernal for consulting gastroenterology. C. Kent DeBose for consulting orthopedics. Matthew Davey in dermatology. Michael Del Clore for consulting cardiology. Anish Keshwani for consulting emergency medicine. Rachel Person for advanced practice professional. Michael Rasmussen for advanced practice professional. Jacob Ritter, advanced practice professional. James Sheehan for consulting dermatology. Sarah Stevenson, advanced practice professional. And Anjar Talukdar, I believe, for consulting vascular medicine. And we have 10 voluntary withdrawals. Cheryl Manisil for consulting radiology. Nicole Thomas for advanced practice professional. Adam Baxt with consulting telecritical care. Adam Evans with consulting telecritical care. Andrew Freeman with consulting telecritical care. Dominic Rascona with consulting telecritical care. Hala Rodadia with consulting telecritical care. Jeffrey Sadowski, same with consulting telecritical care. Sir Samra with consulting telecritical care. And Foreign Sug Betun, I believe, with consulting telecritical care. That would be the adjustment.
I commend you, Tom, on the careful and respectful pronunciation you put into those difficult names.
I do what I can. Wouldn't think you'd run into them in Dane country, but.
Probably not likely, but yes. So I would entertain a motion then to act on the credentialing report as Tom has presented. Anyone?
I'll make that motion.
Greg, thank you. Second?
I'll second it.
Leona seconds. All those in favor of this month's credentialing report as presented, say aye.
Aye.
Opposed, same sign. Motion carries. Thank you. Barry, CEO reports for this month.
On occasion, I'd like to talk about or give you an update on Health Partners of Southwest Iowa. So a little bit shorter meeting here today, so I thought I would include that on the agenda. So Health Partners of Southwest Iowa, I think you all are somewhat familiar with that entity. It's a 28E agreement between Cass County, Montgomery County, and Myrtue Medical Center, hospitals in Harlan, Atlantic, and Red Oak. It became a kind of a formal 28E agreement in '96, but those 3 organizations have been working together, on various joint ventures since the early '80s. I believe. So we things like, share ideas, capital, human resources, just really trying to improve quality of healthcare and do it in an affordable way in our 3 critical access hospitals. We do have a governing body that is made up of the 3 CEOs, and we meet on a quarterly basis. Right now, I mean, there's been a lot of things that we've done over the years, but right now the 4 areas that we work on, it's operation of a mobile nuclear medicine scanner, and really mobile X-ray has been what's kind of pulled this organization together for many years. I think we've always had some type of a mobile X-ray service that has been a part of Health Partners Southwest Iowa. But so in addition to that, we've been doing credentialing services for many years and just started payer enrollment services in 2017. So those are 2 services that are provided out of Myrtue Medical Center. The mobile unit is based out of Atlantic. And then we also have some mannequins, 2 mannequins that we utilize to educate staff that we share with the other 2 hospitals. As far as nuclear medicine, just to give you an idea how many scans we're doing, we did 485 for the year ended June 30, 2020. We did 142 Cass, 199 in Montgomery, 144. We are looking at potentially having that be an in-house service down the road. I think Atlantic would like to have that happen fairly soon. We would have to have a little bit of space, and I think Red Oak is, I don't know if they're in a position with their space. It's not a huge room, but it would take some space. We talked about maybe a specialty clinic would be a good location, and we also obviously talked about it as part of our master facility. But as of now, we're continuing to use the mobile truck. It is getting close to end of life. It's pretty much fully depreciated. So we may need to be making a decision on that fairly soon, whether we want to move to in-house. It's become a lot more affordable to go that route. We would potentially then share a tech between maybe 2 of the organizations or for all 3. So that would be a big change in what we would be doing with Health Partners moving forward. But as of now, we're still in the mobile truck. Credentialing, just a little background, and Ann Buman does oversee this, so she understands it better than I do, but primary source verification, so things like verifying graduation, internships, residencies, fellowships, various hospitalizations, licensures, certifications, malpractice insurance, references, board certifications. Those are the types of things that they're verifying through the credentialing process. And they also do the data collection, file maintenance. So right now we have 20 facilities. I think we've as high as maybe 22 or 23 facilities. So we did lose a couple facilities in the last couple of years, but approximately 1,200 providers that they do credentialing for. And then payer enrollments, the new service that we started in 2017. We have 6 hospitals, including the 3 hospitals, approximately 50 providers. So that's getting all the paperwork done so that we can get reimbursed appropriately by Medicare, Medicaid, and all the commercial insurances. And this is the group here at Myrtue that handles the credentialing and payer enrollment. And then the simulation mannequins, we've owned those probably, I guess I don't know, it's probably been 5 or 6 years. We really didn't do a lot with them this last year with COVID, but we do rotate those mannequins through the 3 different organizations and provide them education of staff. And they are looking at getting that going again here in the next few months. We'll probably have to be looking at replacement of the mannequins here in the next couple of years as well. And just financially, this organization, we have total assets of $1,876,000. Most of that is cash and CDs, about $1.7 million. We've talked about finding some services that we could put that money to work, and we haven't come up with a good solution on that here in the last couple of years. We have also talked about maybe taking a cash distribution, but I think all 3 entities are in a pretty good position with cash right now, and so we've left those dollars within that organization. The nuclear medicine truck, as I mentioned, it's getting very close to being fully depreciated. That's got net value right now on the books of $33,000. Total liabilities, $72,000. So the net assets, about $1.8 million. So on each of the hospital's financial statements, their balance sheets, there's a line item for about $600,000 for our investment in Health Partners of Southwest Iowa. Just giving you a little information on how they do operationally this last fiscal year. The 3 different service lines, you can see what their gross revenue is, and total gross revenue of $868,000. The net profit for each of those lines, each of them did have profit. Nuclear medicine, $79,000, credentialing, $18,000, and payer enrollment, $109,000. So, and then we had some administrative costs. It came down to a total net profit of $197,000 for that organization. So are there any questions on Health Partners of Southwest Iowa? Just like to give you a little update on that from time to time. I think it's been maybe 3 years since I provided an update on that organization. So,
do you know of any other causes that are in this kind of a partnership at the state?
I think there's different joint ventures throughout the state. I don't know that I would say there are 20 AD agreements, governmental entities, but yeah, I think there's a lot of different organizations throughout the state that are somewhat similar to this. I think
this
hospitals
is just interesting, the duration of it. That's a long time relationship for 3 groups like this to be operating that way, so good goals, good targets, sharing of resources.
It's been a valuable organization for all 3 hospitals over the years, so. I did want to just give you, I won't say a lot about this. So the virtual hospital day on the Hill is on Wednesday from 4 to 5. I think Ruth maybe has the information if you'd like to get on that event, but Governor Reynolds is going to open that up, and then we'll also have Kirk Norris will speak. Tom Nichols is Executive Vice President for Government Relations and Public Policy for the American Hospital Association, so he will speak as well. We'll find out a little bit more about what our advocacy agenda is for this current year. I also have a IHA board meeting on Thursday, so we'll learn a little bit more about that at that time. I do know that telehealth parity is a big item for advocacy this year. Obviously with the pandemic, we've seen a huge growth in telehealth. It may drop off a little bit moving forward, but I think everybody's realized that it makes sense, and it's a way to provide good quality care, and it's going to be utilized moving forward, and we would like to get paid appropriately for it as well. So that's that's definitely on the agenda. Tort reform has gotten a little bit more movement again this year. There is House legislation right now, as of last week when I looked at this, that was moving forward. I'm not sure what's happened in the last 4 or 5 days with that, but so the idea there is to cap non-economic damages, things like, you know, pain and suffering, inconvenience, you know, mental anguish, emotional pain, those types of things. So we do have a cap in Nebraska, but Iowa has never had a cap on non-economic damages. And the cap they're looking at is $1 million. Historically, Iowa hasn't had really huge verdicts. Just up until the last maybe 4 or 5 years, there's been 5 verdicts totaling $85 million just in those last few years. And 75% of those damages of that $85 million was non-economic damages. And so in a lot of cases, trial attorneys aren't even really going after the economic damages, which is things like, you know, medical expenses, lost wages, because they know there's such a potential for a large settlement. And it's impacting hospitals, you know, can't be paying out those kind of damages, and the malpractice premiums are going up. In some cases, in some of the more high-risk services, it's hard to get coverage for malpractice, OB and surgery. So that's high on the list right now. It was part of the 2019 advocacy and didn't really go anywhere, but looks like it's getting support this time around.
Trial attorneys are pushing a lot of bets on it, trying to defeat it.
Sure, yeah. Yeah. And then I think mental health payment is another one that is going to be on the agenda again. I don't really have a lot of information on that at this point, but we will learn more about that over the next week or so. So that's my report for today.
I was going to say Wednesday, if anybody, registration is still available. So virtually is convenient. We need to travel to the Capitol. So if you can do that yet this week, it's 4 o'clock on Wednesday. Thank you, Barry, and we'll hear more from you on that in future meetings as you get more information as well. So great. Anybody have questions for Barry about anything? Okay, we'll move on to the financials. Christy, statements for January.
Okay, the condensed financial report for the 7 months ended was, we had outpatient and behavioral health visits in the month of January of 2021 of almost 5,000. We had over 5,500 last year. We're about 37,700 for the year, compared to 39,837 last year. So we are still seeing declines in our visits, potentially due to COVID. The ER visits, we had 330 in January 2021, 488 in January 2020, 2,700 for the 7 months ended, compared to 3,372 last year, which is a pretty big decrease there too. Surgical procedures were the same in January 2021 at 115 as they were in January 2020. We've done 838 in this fiscal year, and for the same 7 months last year, we did 927. The physician clinic visits were 3,103, 4,197 last January. Year to date, we had 23,819 compared to 27,296. Our average daily census for January 2021 was 9.62 compared to 12.79 last year. Year to date, we're pretty comparable at 9.25 compared to 10.6. We had 3 births in January 2021, 6 in January 2020, 27 year-to-date, compared to 45 last year. We do anticipate with our OBGYN, that will be increasing. So for revenues for January 2021, we had almost 3.8 million, almost 3.8 million in operating expenses, and 607,000 in other net operating revenues and expenses. So we had a net income from all sources in January of this year of 624,180. Biggest change there is in that net non-operating is the forgiveness of our PPP loan, which is over $400,000. In January 2020, we had 3.8 million, pretty much the same revenue, pretty much the same expenses also, and 104,000 in non-operating net. So we had 142,000 in January 2020. Year to date, we're at 25.3 in net operating revenue, 25.8 in net operating expenses, 2.9 million in non-operating net, or 2.3 million net income from all sources for this 7 months. In 2020, we had almost 26 million in revenue, almost a little over 25.6 million in expenses, and 708,000 in non-operating net for a net income from all sources of 942,000. Again, a lot of that has to do with our PPP loan and recognition of some of our CARES Act funding that we are using for COVID expenditures. In your packet was the detailed financial reports. Our cash has increased, still seeing increases from last year. Our AR is down approximately 9 days from where we were, 10 days from where we were last year at this time. So we have a 9.9 in patient accounts receivable compared to 13 million last year. That's one thing we did see with COVID, and it's pretty consistent across other hospitals I've talked to, is as folks were not able to go do a lot of things, they took the opportunity to pay down some of their bills, which was helpful. Liabilities remain consistent. So we're still sitting in a really good financial position at this time. Any questions on those financial reports? I did want to mention in your packets that there is a revised, we went over the investment report last time, and there was a revision of that. Our New York Life investment did have additional income. So really, for the end of the year, for at 12/31/2020, we did have a 3.8% average rate of return on our investments, our CDs, our money markets, and our equity investments within New York Life. So really a pretty good return this last year. So we did revise that for correction that needed to be made.
Okay. Questions for Christy?
New York Life, been there a year, or just a little over a year. Invested $1 million in it. It went down quite a bit right at the beginning of COVID, and then it's come back. Right.
3.88. That's better than a lot of banks, so that's great.
Overall, yeah.
Thanks for that information. Entertain a motion to approve the financial statements as shared this morning.
I'll make it.
Leona, I'll take you first, and Janine, will you second that?
I would be glad to.
Thank you. All those in favor say aye.
Aye.
Aye. Opposed, same sign. All right, and the approval of January payroll and claims, please.
So moved.
Tom's moved. Is there a second for approval on payroll and claims?
I'll second.
Rick, thank you. All those in favor of approving payroll and claims say aye.
Aye.
Opposed? Fine. All right. And I would entertain a motion to adjourn, because we're at that point.
So moved.
Tom moves. Is there a second?
Second.
Jim's got the second. All those in favor of adjournment, say aye. Aye. Thank you all very much. Continue to stay safe and, look